Okay, let's unpack this. Imagine finding a mass in a dog or cat's chest, right where their heart and lungs are,
Hmm.
and then discovering it's causing problems way off somewhere else, like in their limbs or maybe their skin, or even making it impossible for them to swallow properly.
Yeah,
It's like the tumor is somehow pulling strings for the rest of the body.
it really is. It's one of the most striking examples in vet med of how a seemingly local issue can have these really profound systemic effects. These distant effects are often what we call paraneoplastic syndromes,
Right.
and they are absolutely critical to understanding this specific tumor.
And that specific tumor is what we're diving deep into today.
Yeah.
Canine and feline thymoma. We're basically sifting through the source material you shared to pull out the crucial
Yeah, the
insights.
need-to-know stuff.
Exactly. Not just facts, but the really important nuggets. Our mission here is to give you that shortcut, that curated overview, so you're well informed about thymoma, who gets it, what those often surprising signs look like, how we actually track it down, what treatments work, and what the outlook really is.
So at its core, a thymoma is a neoplasm, a tumor, and it grows from the epithelial cells of the thymus gland.
Okay, the thymus.
Yeah, the thymus is located right there in the cranial mediastinum. That's the space in the chest, kind of in front of the heart and lungs.
Right.
And it's a really vital organ, especially when animals are young, because that's where T lymphocytes mature. It's where they learn to tell self from non-self for the immune system.
Okay, so it's tied into the immune system. That might start explaining some of those weird distant effects you mentioned. Is it like a common tumor?
No, actually, it's considered pretty rare overall.
Yeah.
But, and this is important, when you do find a mass in that specific spot, the cranial mediastinum, thymoma is actually the second most common cause you'd think of.
Oh, really?
Yeah, right after lymphoma. So while it's rare generally, it's definitely a major player, a key differential for any mass you find right there.
Got it. Okay. Rare overall, but high on the list for chest masses after lymphoma. So, who tends to get this? Any particular type of dog or cat more prone?
Generally speaking, it's a disease we see in older animals. For dogs, the median age is typically somewhere around, say, 9 to 11 years old.
Okay.
Some studies mention medium to large breeds might be more common, maybe German Shepherds, Labradors.
Hmm.
But the sources don't universally agree on a really strong breed link.
And what about cats? Similar story.
Older cats too, yeah.
Mm.
Often the median age is even a bit higher, maybe 10 to 12 years. And for cats, there really isn't a significant breed predilection noted in the material.
All right, so let's get into what you actually see. When an animal presents with a thymoma, because this sounds like where things can get complicated, maybe even confusing if you don't connect the dots. You mentioned signs kind of fall into two main buckets.
Exactly. So first, you've got the signs that are directly caused by the sheer physical presence of the mass.
Hmm.
It's just taking up space in a very crowded area of the chest.
Well, it's literally pressing on things.
Precisely.
Hmm.
And the most common things you see from that pressure are respiratory signs. That mass can push on the trachea, the windpipe, or the lungs themselves,
Leading to.
leading to things like coughing, breathing fast, that's tachypnea, or difficulty breathing, dyspnea. Maybe they just can't exercise like they used to.
Makes sense. It's all packed in there. What else is nearby that could get squished?
Well, the esophagus runs right through there, too.
Mhm.
So compression at the esophagus can lead to regurgitation, or sometimes vomiting.
Okay.
And then there's a more serious one, which is compression of the cranial vena cava. That's a major vein.
Uh-oh. That sounds bad. What happens then?
That causes something called cranial vena cava syndrome. If that big vein bringing blood back from the head, neck, and front legs gets squeezed, blood just backs up.
So you'd see swelling.
Exactly. You'll see swelling, edema in the face, the neck, maybe the forelimbs. And this often goes hand in hand with pleural effusion,
Which is fluid.
fluid buildup around the lungs,
Yeah.
which of course makes breathing even harder, on top of any direct lung compression.
Okay, so those are the direct squishing problems. But then there are these paraneoplastic syndromes you mentioned. These are the ones that seem totally disconnected from the chest, right?
They really are. And honestly, they are often the most clinically obvious signs,
Hmm.
the things that bring the pet in. Sometimes they're even the most life-threatening parts of the condition.
Wow.
They're effects caused by substances the tumor might be making, or maybe the tumor triggers some kind of abnormal immune response. But the key is they show up far away from the tumor itself. It's not because the tumor is spread there.
And the classic one, the one everyone links with thymoma, is myasthenia gravis, right? MG.
Absolutely. Myasthenia gravis, MG. It's the most common and probably the most clinically significant paraneoplastic syndrome we see in dogs with thymoma. It could affect up to, say, 40% of them in some reports.
40%. That's huge.
It is. It's less common in cats, but definitely still reported.
And how does that work? I mean, how does a tumor in the chest cause muscle weakness all over?
So this is where it gets really fascinating, and it ties right back to what we said about the thymosin immunity.
Oh.
The thinking, based on the sources, is that the thymoma can actually mess up that normal immune training process in the thymus. It disrupts immune tolerance,
Meaning
the body can start producing antibodies that attack its own tissues. In the case of MG, it attacks the acetylcholine receptors. These are at the neuromuscular junction, basically, where nerve tell muscles to contract.
so the body attacks the communication points for muscles.
Exactly. It blocks those receptors, and the result is profound muscle weakness.
Wow. So the tumor basically tricks the immune system into attacking the muscles. What does that, look like in the dog or cat?
Well, it looks like severe muscle weakness. Often, it's triggered or gets much worse with exercise. You might see a dog start a walk just fine,
Yeah.
and then get progressively weaker, maybe even collapse.
Oh, wow.
Difficulty swallowing dysphagia, that's common, changes in their bark or meow, facial weakness, maybe droopy eyelids. Those are all classic signs, too.
And the swallowing problem, the dysphagia, that links directly to megaesophagus, doesn't it?
That is such a critical connection, yes.
Yeah.
Megaesophagus, which is this big dilation and loss of normal function of the esophagus. It's a very common result of the swallowing weakness you see in MG.
Right.
Because the esophagus can't push food down properly. The food just sits there, pools, and then it often gets regurgitated back up.
And the number one danger with regurgitation in a floppy esophagus like that?
Aspiration pneumonia, without a doubt. That's when food or liquid gets accidentally inhaled down into the lungs instead of going down the esophagus.
And that's really serious.
It's incredibly serious.
Yeah.
It is potentially life-threatening, and it definitely makes the short-term prognosis much worse.
That whole chain reaction MG causing swallowing issues, which leads to megaesophagus, which then puts them at high risk for aspiration pneumonia. That seems like one of those absolutely critical takeaways for anyone listening.
It really is.
And I think I remember the source highlighting something specific about treating the MG if aspiration pneumonia is already happening.
Yes, absolutely vital point. The source material is very clear on this. While we often use immunosuppressants, like prednisone, to manage the underlying immune attack in MG,
Right.
you absolutely should not use them if the animal currently has aspiration pneumonia.
Why not?
Because the priority has to shift entirely. You need to aggressively treat that lung infection first, usually with antibiotics, supportive care.
Yeah.
Giving immunosuppressants would just weaken their ability to fight off that dangerous infection.
Okay, that makes perfect sense. Treat the fire before you worry about the faulty wiring that started it.
Ex-
Are there other sort of bizarre paraneoplastic things besides the muscle and swallowing stuff?
Oh, definitely. Exfoliative dermatitis is another really striking one. You see this more often in cats with thymoma.
Skin problems from a chest tumor.
Yeah, it's a severe, often widespread skin issue. You see lots of scaling, crusting, hair loss. It often starts pretty dramatically on the head and ears. But again, it's a chest tumor causing a major skin disease, another example of that systemic effect.
Wild.
Yeah.
Anything else pop up?
Yes, hypercalcemia. That's elevated calcium levels in the blood. It's reported in maybe 5 to 10% of dogs, although one source mentioned a study where it's closer to 30%.
And what does high calcium cause?
The classic signs are increased thirst and urination, PUP we call it, plus lethargy, maybe loss of appetite, sometimes GI upset like vomiting.
Okay. And any rarer ones mentioned?
Less commonly, yeah. You can see bone marrow suppression, which leads to things like plastic anemia or pure red cell aplasia, basically not making enough blood cells. Polymyositis, which is inflammation of the muscles themselves, causing pain and weakness separate from MG. And very rarely other immune problems like IMHA or IMT, immune-mediated anemias or thrombocytopenias.
Oh, okay. Wow. So you've got this older animal, maybe they have some breathing trouble, but maybe they also have this weird muscle weakness or they're regurgitating or they have this awful skin condition. How do you actually go about diagnosing thymoma? And maybe more importantly, how do you make sure it's not that other big one, lymphoma, in the same spot?
Yeah, it's definitely a multi-step process. It always starts with a really thorough physical exam.
Yeah.
You're looking carefully for all those signs we just talked about, maybe doing specific tests for muscle strength or checking their swallowing reflex if MG's on your radar.
Then blood work, I assume.
Yep. Standard blood tests, CBC, biochemistry panel. Maybe a urinalysis, give you the overall health picture. You might pick up anemia or that high calcium or maybe elevated muscle enzymes if there's polymyositis going on.
Okay.
But if myasthenia gravis is even a remote possibility based on the signs, then the acetylcholine receptor antibody test is absolutely essential.
And that confirms MG.
A positive result pretty much confirms MG. And because MG is so strongly linked to thymoma, a positive test really bumps thymoma way up the list of possibilities as the underlying cause.
Okay. What about actually seeing that mass in the chest, imaging?
Right. Chest x-rays, thoracic radiographs are usually the first step. They'll typically show you that mass in the cranial mediastinum. You might see the trachea getting pushed aside. You might see that pleural effusion fluid around the lungs.
Which you said is common in cats.
Very common in cats with thymoma, yeah. Sometimes it's even a specific type called chylothorax. And the x-rays might also show signs of megaesophagus, if that's present.
And does ultrasound add anything?
Thoracic ultrasound can be helpful, too. It can sometimes help characterize the mass a bit more. For instance, thymomas can sometimes have cystic, fluid-filled areas inside them, which is less typical for lymphoma.
Ah.
And ultrasound is also really invaluable for guiding sampling, like getting a fine needle aspirate of the mass itself or sampling the pleural fluid if it's there.
So x-rays show the mass is there. Ultrasound helps look at it, maybe sample it. But for the really detailed look, especially before thinking about surgery.
Then a CT scan is highly recommended.
Yeah.
Many would consider it the gold standard for this situation.
Why CT?
Because it gives you that incredibly detailed cross-sectional 3D view. It's crucial for figuring out the mass's exact size, its relationship to all those vital structures nearby, the big blood vessels, the heart, the lungs, and importantly, whether it looks like it's invading into any of those structures.
Which tells you if surgery is even possible.
Exactly. That information is absolutely critical for surgical planning, for assessing resectability. Plus, the CT can give you a good look at the lungs to check for any signs of metastasis, spread, although thankfully that's pretty uncommon with thymomas.
Okay, so imaging shows the mass, maybe suggests thymoma. Now you need proof. You need to know what kind of cells are in there. Sampling is next.
Right. Getting a tissue sample, fine needle aspirates, often guided by ultrasound or CT, are very common first steps.
And what do you see under the microscope? On cytology.
You're looking for a characteristic mix of cells. The key is finding neoplastic epithelial cells. Those are the actual tumor cells mixed in with a population of lymphocytes. Remember, the thymus is full of lymphocytes.
Is that mix always easy to spot and definitively say thymoma, not lymphoma?
Well, that's one of the big diagnostic challenges. It can actually be pretty tricky based on cytology alone.
How so?
Because lymphoma, especially thymic lymphoma, is typically just a uniform sheet of large, abnormal-looking lymphoid cells, lymphoblasts. Thymoma has that mixture, the epithelial cells plus lymphocytes, but the lymphocytes in thymoma are often mostly small, mature-looking, and kind of variable, heterogeneous.
Oh, I see.
So seeing those epithelial cells and seeing that mixed, mostly mature lymphocyte population points you away from lymphoma. But it definitely requires an experienced cytologist to make that call confidently sometimes.
Are there other tests on those samples that can help tell them apart?
Yes, absolutely.
Yeah.
Flow cytometry, or another test called PA-SHAR, can be run on the aspirate samples. This goes back to the immune cell types.
Okay.
Thymomas typically have what's called a polyclonal population of T lymphocytes. Often they have a specific marker pattern too, like being positive for both CD4 and CD8. We call them double positive T cells. Lymphomas, being cancers of a single cell line, are usually monoclonal, just one type dominating. So these tests can be really helpful when the cytology is ambiguous.
And the absolute final word, the definitive diagnosis.
That usually comes from a biopsy and histopathology. That's where they look at the actual tissue structure, not just loose cells. Often this is done on the tissue that's removed during surgery. But sometimes, if surgery isn't planned right away or the diagnosis is really uncertain, an incisional biopsy might be done first.
Okay. So before you get that definitive thymoma diagnosis, what are the other main things that could cause a mass in that cranial mediastinal spot?
Well, as we've said, thymic lymphoma is #1 on the rule-out list, especially in younger animals, because it also arises right there in the thymus.
Right. What else looks similar?
You could potentially have enlarged lymph nodes in that area, mediastinal lymphadenopathy, from some other cause. Maybe an ectopic thyroid carcinoma, thyroid cancer in the wrong place. Chemodectoma, which is a tumor of chemoreceptor cells near the heart base. Sometimes benign things like thymic cysts, or even inflammatory stuff like abscesses or granulomas. Less commonly, other types of sarcomas or carcinomas could pop up there too.
Okay, quite a list. So let's say you've navigated all that. You've got the diagnosis. It is definitely a thymoma. What's the game plan? It sounds like you've got two big things to tackle: the mass itself and potentially those really serious syndromes.
Absolutely. And the cornerstone of treatment, assuming the tumor looks resectable, is surgery. A thymectomy, removing the thymus gland and the tumor.
And that's the best shot.
For a tumor you can remove, yes. Surgical removal offers the best chance for controlling the tumor locally, for getting those paraneoplastic syndromes to improve or even resolve completely, and ultimately for achieving long-term survival.
How do they actually do that surgery? It sounds complex.
It is major surgery. The most common approach is called a median sternotomy. That involves actually splitting the sternum, the breastbone, right down the middle. It gives the surgeon the best view and access to that whole cranial mediastinal area.
Wow.
For smaller masses that are clearly off to one side, sometimes a lateral thoracotomy going between the ribs might be an option.
Is getting the whole tumor out always possible or straightforward?
Not always, no. Thymomas can be locally invasive. They can grow into surrounding structures. The source material actually notes they tend to be a bit more invasive in dogs compared to cats, which can make getting complete removal more challenging sometimes.
Which is why that CT beforehand is so important.
Exactly. That pre-op CT is vital for understanding how invasive it looks and really predicting whether a complete removal is feasible.
What kind of results can people expect after surgery? I mean, can it actually cure the animal?
Yes, a cure is definitely possible, especially if the tumor is non-invasive and the surgeon achieves complete removal. The survival times are significantly better compared to not doing surgery.
How much better?
Well, studies report median survival time somewhere in the range of 1.5 to 2 years in dogs after surgery, and maybe even 3 to 4 years in cats. One dog study really highlighted it. Median survival was 635 days with surgery versus a pretty grim 76 days without.
That's a massive difference.
Huge. And for tumors that are considered resectable and don't have that complication of megaesophagus, the numbers can be even better. Over 80% alive at 1 year, and median survivals reported over 1,800 days in cats and close to 800 days in dogs in some studies.
Incredible. Are there significant risks with the surgery itself, though?
Yes, it's important to be aware of that. There is a risk of perioperative mortality dying during or shortly after the surgery. The sources quote figures in the range of maybe 20–22% in some studies.
That sounds high.
It reflects the complexity of chest surgery, definitely, and also the fact that these patients are often quite sick to begin with, especially if they have severe paraneoplastic issues like MG or aspiration pneumonia. That makes them more fragile surgical candidates.
Okay, so what if surgery isn't an option? Maybe the tumor is just too invasive, or the owner declines, or the animal isn't a good candidate. What then?
Then radiation therapy is usually the next best approach. It's quite commonly used.
In what situations?
It can be used after surgery if the surgeon wasn't able to get all the tumor out. We call that adjuvant therapy to clean up residual disease. Or it can be the main treatment if the tumor is considered non-resectable from the start, or if surgery just isn't possible for other reasons. Sometimes it's used palliatively just to shrink the mass and relieve some of those pressure signs. And thymomas are generally considered moderately sensitive to radiation.
Meaning it works reasonably well.
Yeah, many tumors show a good response, either shrinking significantly, partial response, or sometimes even seeming to disappear on imaging, complete response. The reported median survival times with radiation therapy alone are pretty decent, around 248 days for dogs, maybe 720 days for cats. So it can definitely provide significant disease control.
Are there different types of radiation?
Yes, they might use conventional fractionated radiation or sometimes more advanced techniques like stereotactic radiation, SRS or SRT, which deliver higher doses more precisely.
Okay. What about chemotherapy? Does that play a big role here?
The source material suggests that chemo by itself isn't generally thought to be highly effective against thymoma. There's actually limited published data on it.
So not a primary treatment.
Not usually, no. It
Sure.
might be considered as an add-on, maybe after surgery if there's still disease left, or there's evidence of metastasis. But again, spread is uncommon.
What about steroids like prednisone?
Corticosteroids like prednisone are often used. They serve a couple of purposes. They have a lympholytic effect, meaning they can kill lymphocytes. So in thymomas that have a lot of lymphocytes mixed in, prednisone can sometimes cause tumor shrinkage, at least temporarily.
Right.
And crucially, steroids are often essential for managing many of those immune-mediated paraneoplastic syndromes we talked about, especially the MG.
Okay, let's talk about managing those syndromes specifically then. If myasthenia gravis is present, what's the approach?
For the MG itself, the main drug used to improve muscle strength is pyridostigmine. It's an anticholinesterase inhibitor, basically helps the nerve signals get through to the muscles better, overcoming the receptor blockage. And then, as we mentioned, immunosuppressants like prednisone are often added to try and calm down that underlying immune attack on the receptors. But always remembering that critical warning.
Don't use it if there's active aspiration pneumonia.
Exactly. Got to treat the pneumonia first.
And the megaesophagus. Managing that sounds like it needs a very practical, hands-on approach.
It absolutely does. The main goal is minimizing the risk of aspiration. This is where teaching owners about elevated feeding becomes so important.
Like using a special chair.
Yeah, using something like a Bailey chair, which holds the dog upright, is ideal.
Mm-hmm.
Or even just holding them vertically or having them sit up on stairs for feeding and then keeping them upright for maybe 15-20 minutes afterwards, letting gravity help the food down.
Okay.
Often, feeding smaller amounts more frequently is better tolerated than big meals. And in really severe cases, sometimes a feeding tube is necessary to make sure they get enough nutrition safely, bypassing that non-functional esophagus altogether.
Do these syndromes, like the MG or the skin issues, just sort of magically disappear once the tumor is removed?
Well, that's the hope, and often they do. Ideally, surgically removing the thymoma leads to resolution or at least significant improvement of the paraneoplastic syndromes.
Yeah.
That includes MG and that feline exfoliative dermatitis too.
But maybe not instantly.
Right. It's really important to manage expectations there. The improvement isn't always immediate. It can sometimes take weeks, maybe even months, for that immune system dysregulation to fully calm down and for the signs to completely resolve after surgery.
Okay.
And other syndromes might need ongoing management too, like the dermatitis might need immunosuppressants until the tumor's effect wears off. Hypercalcemia usually needs managing with IV fluids, maybe diuretics, sometimes corticosteroids, depending on what's driving it, until the tumor's gone.
So pulling it all together then, the prognosis seems quite variable, but often potentially quite good, especially if you can get that tumor out surgically.
Yes, I think that's the key takeaway. Resectability, whether or not the tumor can be surgically removed, is probably the single most important prognostic factor.
Makes sense.
If you can get complete surgical removal of a non-invasive tumor, the prognosis is generally excellent. There's potential for a cure. And even for tumors that are more invasive but still removable with aggressive surgery, prolonged survival is definitely possible.
And the syndromes, how do they factor into the long-term outlook?
Well, the presence of paraneoplastic syndromes, especially that dangerous combination of megaesophagus with aspiration pneumonia, definitely worsens the short-term prognosis. It increases the risks around surgery and recovery.
Right.
But if the animal gets through that initial period and the syndromes resolve after surgery, the long-term prognosis can still be quite good. Some sources also mention that tumors with a higher proportion of lymphocytes might perhaps carry a better prognosis, but resectability is still king.
What about the tumor coming back? Recurrence?
Recurrence is definitely possible. It's reported in maybe around 17% of cases after surgery. Interestingly, though, the source material notes that even if it does recur, sometimes a second surgery can still be successful. And it's also worth mentioning, for those animals where surgery isn't an option, or maybe the tumor is just monitored, the sources do say that some thymomas behave in a very slow-growing, indolent way, and some individuals can have surprisingly prolonged survival even without aggressive treatment.
And follow-up after treatment, what does that typically involve?
Regular follow-up is really crucial. Usually that means recheck exams and repeating those chest x-rays, say, every 1 to 3 months initially, especially in the first year or so. You're monitoring mainly for signs of local recurrence, or much less likely, distant spread.
And if they had MG?
Then you'd also be closely monitoring their muscle function, their swallowing ability. Sometimes vets will even track the acetylcholine receptor antibody levels, the titers, as they hopefully decrease over time after successful treatment.
Okay. If you had to boil this all down for someone listening, maybe a vet tech, a student, or even an owner facing this, what are the absolute must-know messages from the source material we've covered?
I'd say, first, understand the location. It's a mass in the chest, and it can cause problems just by pressing on things. Simple mechanics.
Right.
Second, and this is critical, recognize the potential for those serious, sometimes really counterintuitive paraneoplastic syndromes, especially myasthenia gravis, leading to megaesophagus, and that huge, life-threatening risk of aspiration pneumonia that comes with it.
And the practical management for that?
Yes, emphasize practical steps like elevated feeding if megaesophagus is there, and importantly, reassure people that these syndromes often do improve or even resolve completely once the underlying tumor is treated. It might take time, but it can happen.
Okay. and the core treatment strategy.
That surgery, when it's feasible, is really the primary and most effective treatment for tumors that can be removed. It offers the best chance for long-term survival and getting rid of those symptoms. And radiation therapy is a solid second option when surgery isn't possible or maybe wasn't complete. It's also fair, I think, to acknowledge the realities. While good outcomes are definitely possible, getting the diagnosis, doing the surgery, potentially needing intensive care for complications like pneumonia, and managing syndromes long-term,
Yeah.
it can all involve significant costs.
Yeah, that's important context.
And because of all this complexity, referral to a specialist, like a board-certified surgeon, oncologist, or internal medicine specialist, is often really highly recommended to get the best possible outcome.
This has been a really fascinating deep dive into what sounds like a truly complex tumor. Thymoma seems challenging partly because it's rare, partly because its signs can be so misleadingly distant from the chest, and partly because you often have to manage these severe simultaneous paraneoplastic problems. But it sounds like understanding those complications and approaching treatment aggressively, often with multiple modalities, but really centering on surgery when possible, offers the best path to prolonged survival and hopefully a good quality of life.
It really does, and it highlights just the incredible complexity of the body's systems, doesn't it? Especially when the immune system, which originates in a place like the thymus, gets involved in such unexpected ways.
Yeah, absolutely. Which kind of leaves us with a final thought for you, the listener, to maybe mull over.
Yeah.
How is it that a tumor arising from the thymus, an organ whose entire job, essentially, is to train the immune system to tolerate the body's own tissues, to know self? How can that tumor instead trigger the same immune system to viciously attack the body's own tissues, leading to devastating conditions like myasthenia gravis?
Yeah.
It's really a profound reminder of the incredibly delicate balance within our immune systems, and maybe how easily that balance can be disrupted, sometimes with baffling consequences.